So the call came. How would you like to go to Africa? After I picked the phone up off the floor, found out it was my wife, and I said, "What are you talking about?" You see, we had never talked about being medical missionaries, not even considered it, not for 1 minute. But we received an email that said, if I were a surgeon, I would go. And my wife thought, I think I know a surgeon. Happens to be my husband. And over the course of a year or two, God stirred our hearts, and we ended up going to a country, the country of Gabon on the west coast of Africa, and serving there for 10 years, training and discipling Christian doctors to become surgeons and devoted followers of Jesus Christ. This morning, what I want to share with you, though, is a bit about the global perspective of surgery. And in some ways, this dovetails well with what Jenny just told us about advocacy. You see, there is a problem in public health, and it's that surgery has been neglected. This is not new news to us. It's something that's been around for a while. Back in 2008, Paul Farmer and Jim Kim published this information for us. But what did that look like? Why? Well, you'd heard it said, or maybe you had said it yourself, that in global surgery there's little disease burden. It's really not much of a problem. It's too expensive to treat surgical problems, and it's too complex. And, well, there's just too many other initiatives that are much more important than surgery. And the high-income countries, they'll fix it. Let's look at those things and see how that's borne out. So this is from the Lancet Commission. Lancet Commission is a group that investigates specific problems, usually medical problems, and does an in-depth study of what's going on with those medical problems. So in 2015, they published the Lancet Commission on Global Surgery with the idea of looking at universal access to safe, affordable surgical and anesthesia care when it's needed. What is the status in the world of surgical care when it's needed? Let's give a little bit of background here. This is for the disease burden. So the global burden of disease, I want to highlight just two aspects of this. The aspects that I'd like to highlight are maternal diseases. So this is looking at developed countries. So developed countries and the people that need surgery who are admitted to the hospital with that disease category. So as you look at maternal diseases, over 30% of women admitted to the hospital with a maternal problem need surgery. Over 60% of those, if you look at the second arrow there, over 60% of those with cancer who are admitted to the hospital require surgery. This is in the developed world, but it's in a way that we can extrapolate maybe what are the needs in the developing world surgically. So as we look at that, the Lancet Commission came up with this conclusion: 30%, 1 in 3, of the global disease burden is surgical in nature. 1 in 3. And what have we been doing as a global community with surgical problems? What have we been doing? Lancet Commission came to this next step of a conclusion when they were looking at availability and safety, affordability, and timeliness, that most of the world lacks access to surgical care. In fact, it's 5 billion people. So if we were a representation of the world in this group right here, I think the line goes about right here, and all of you don't have access to surgery. So if you're a woman and pregnant and need a C-section, it isn't going to happen for you. If you have an incarcerated hernia and a bowel obstruction, you're not going to get surgery. That's over here. But you guys, fortunately, you're in the right place. You get to have surgery and have your life saved. Previous projections were interesting. They said it was just 2 billion. And that sounds like a lot, right? 2 billion is still a lot. What they looked at was where there's an operating room. So if you were not close to an operating room, then you were part of that 5 billion that had access. The problem is they didn't look at what was actually in the operating room. Was there a surgeon? Nope. Was there materials? Was there suture? Was there an operating table? Was there a nurse? There was nothing else. None of the other support. Was there an anesthesiologist? None of the other support was there. And when you look at it from that perspective, to actually be able to deliver the care, not just that the facility exists, then all of you, 5 billion, have no access to surgical care. So the next thing was, it's too expensive. We can't do surgical care. That costs a lot of money. You have to have instruments, and you have to have a room, and you have to have drugs. You have to have all these things. So this graph here looks at disability-adjusted life years and the cost to save one life year. This is HIV that you see there. It's between $450 and $650 to save 1 year. Look at all the surgical problems there on the left. So tell me, is it too expensive to provide surgical care? I would say it's not. Some of the surgical care that can be provided actually is provided the same result and cost as vaccines, which we all know save lives. Surgery is not too expensive, and there's plenty of disease burden. So let's move on to a couple of other topics here. Is it too complex? Are there too many initiatives? And I know you're saying, yeah, that's fine for you to say. You're a surgeon. It doesn't sound too complex for you. That's true. But it's not just about the surgeon. The complexity involves many other factors. And so let's look at those. So the Lancet Commission took a look at 10 factors that are necessary to provide surgical care. 10. Not 100, not 1,000, 10. I want to just highlight 4 of these for you because I think this is where we can make an impact, and this is where myself with PAACS, the Pan-African Academy of Christian Surgeons, has been able to make a significant impact. The first one is training surgical providers. You have knowledge, someone else needs it, you should give it to them. That's training. It's really not much more complicated than that. The other 3 here are about quality of care and documentation. We're pretty good at that in this country. We're pretty good at doing those things. We can provide that for the rest of the world. We can do it. It's about risk assessment. It's about 24-hour surgical coverage. So the conclusion is that surgery is an indivisible, indispensable part of healthcare. You do not have an adequate healthcare system if it doesn't involve a plan for surgical care. A developing country that has a plan to treat HIV, a plan to give vaccinations, a plan to deal with tuberculosis, but has no plan to address the surgical needs of their country does not have an adequate health plan for their country. It's ineffective and incomplete. So what about the idea of too many initiatives? I think this one I'll probably grant you. This graph here demonstrates if you look at the global health indicator databases and you do a search, you type in a keyword, if you pick the keyword child health, that's what you get on the right. A lot of hits. We all love kids. That's great. I don't have a problem with that. But if you look on the left, that's where all the surgical problems lie. If you search the word surgery, I'm not even sure you can barely find it, but in a couple places. If you search burns or wounds or operation, it's just not there. So are there too many initiatives? There are. But I would challenge you to say that surgery is an important initiative that needs to come to the table globally for global health issues. How about the high-income countries and their surgical community? Well, I guess the answer to that one is clearly no, because I wouldn't be standing here giving you this talk if we had already answered the problem, right? I wouldn't be here. But let's look at it this way. In Sub-Saharan Africa, they did a survey, and they looked at the hospitals that could provide surgical care, and they said, no surveyed hospital has enough infrastructure to follow minimum standards. None. That's 0. 0. That the World Health Organization has put forth. We're not talking about U.S. standards. We're talking about the World Health Organization. That's what they do. Not even one hospital was adequate in the ones that they surveyed. So as we look at this again, what do we say now? Where do we start is really the question we should be asking. What do we do with this information? We've done the Mythbuster thing. What do we do next? This ought to look very familiar to those of you who were here last night. Dr. Russ White, one of my friends, showed you this. This is the problem of and lack of surgical workforce in the world. Sub-Saharan Africa, a significant problem. You can see in India as well. What I want to present to you, though, is comparing that to this graph, which was very similar to what Rich Stearns showed you last night as well, which talks about the unreached people groups, and he correlated that to poverty. So the poverty and the overlap of unreached people groups is quite high. What about the surgical workforce? I don't think it takes a rocket scientist to figure out that the lack of surgical workforce also dovetails quite well, unfortunately quite well, with the unreached people groups of this world. Let's drill down on Sub-Saharan Africa. That's where I spent my 10 years in Gabon in Sub-Saharan Africa. Let's drill down a little bit. 56 million people, 56 million people, 1/7 of the United States population need surgery today. That's today, right now. That's not over the next 10 years, that's today. Let's look at Sierra Leone. I just met someone yesterday from Sierra Leone. In Sierra Leone, they have 6 million people and 8 fully trained surgeons. How big is Houston? I think it's about 3.5 million, 5 million. So you get 6 surgeons for all of Houston. How many surgeons do we have in this room? Yeah, I think we have more than 6. That means everybody at MD Anderson has to leave right now. No more surgeons other than what is in this room for the whole city of Houston. It's staggering. So it's the challenge as well, and a biblical inspiration. How are you going to address the surgical needs? We can't do it alone. We need to train people, right? Well, fortunately, as the Bible does, it gives us instructions for almost all of life, actually. And it gives us this instruction. And these things you have heard from me in the presence of many witnesses, teach them to able men and women who are also able to teach others. It's with that inspiration that a few guys and ladies got together to discuss this problem of surgery in Africa, that there are not enough surgeons. As they were looking at addressing the need, they came up with this conclusion to start their own training program, the Pan-African Academy of Christian Surgeons. With this vision, to see African surgeons living the gospel and ministering to the sick. I would be remiss to say that no one was doing that already. There certainly are African surgeons who were doing that. There are just not enough of them to meet the needs. With this mission, training and discipling African surgeons to glorify God and to provide excellent, compassionate care to those most in need. Today, PAACS looks like this. You heard from Russ White last night. Tenwick Hospital is one of our sites. We have 8 other sites across the continent with 12 training programs. We truly wear our name of Pan-African well, and I'm thankful for that. So teach them to able men who are also able to teach others. So what does the product look like? When our residents graduate, are they doing what we want them to do? Are they teaching others? And I would say yes, they are. We have some that are in academia. We have some that are in mission hospitals, but training others. They've invited their compatriots in Northeast Congo. One of my graduates, Jean-Claude Bataneni, is training other doctors at this small hospital called Nebabongo, which maybe you've heard of Helen Roseveare. She started that hospital. So PAACS is making a difference. And you may recognize some people in this picture. Most likely you recognize the guy in the top right corner. It's Kent Brantley. But do you know the guy in the middle? He's a PAACS graduate. His name's Jerry Brown. He was trained in Cameroon, and he's from Liberia. And when Ebola hit, he was instrumental in the response of the Liberian Ministry of Health. He played a significant role. Now you say, well, Keir, that's not surgery. That's true. But remember, our program isn't about training surgeons. It's about discipleship that happens to use the method of training surgeons to disciple these men and women. Was Jerry Brown discipled? Absolutely. Now, would he have done this anyway if he hadn't been in PAACS? Only the Lord knows. But I can tell you that he was more likely to do it having been in the PAACS training program. And this gentleman here, Martin Salia, he paid the ultimate price in fighting Ebola. He died. He gave his life. He is also a PAACS graduate. God is doing significant things through training and discipleship in surgery in Sub-Saharan Africa. So you've heard it said there are too many hurdles to addressing the surgical needs of the world. Maybe you've said it yourself. Maybe it's too daunting. But I tell you that nothing is impossible with God. Nothing is impossible with God. And a few men and women who are willing to stand in the gap. Are you one of them? You may say, but I really want to have a global perspective. The Lancet Commission has brought surgery to global health. Their commission from 2015 has opened a door that we need to walk through as surgeons, as healthcare providers, promoting the surgical agenda. It's very important. Remember, 1/3 of the diseases in the world are from surgical problems. 1/3. We have to walk through that. It's an imperative. And it's an opportunity. Remember where the unreached people groups are? It's the same place that needs surgery. It's the same place that has poverty. We have to get engaged. We must engage. From a biblical perspective, Matthew 28 is clear. Go and make disciples of the people that you would like to see. I don't think that's what it says. Go and make disciples of all peoples, all nations. All. Even those that are poor and that lack surgical access. It's not a challenge as much as it is an opportunity to reach the unreached people groups of the world. And in 2 Timothy 2:2, these things you have heard from me in the presence of many witnesses, teach them to others. So the challenge for you is, will you say yes? Will you answer the call? How would you like to go to Africa? Thank you.